Good morning, everybody. If I could ask you to take your seats. Well, good morning and welcome to this National Summit on Young Onset Dementia. I want to begin by acknowledging the traditional owners of the lands we're all meeting on today. Here in Melbourne, that's the Wurundjeri people of the Woiwurrung and Boonwurrung nations, people of the Kulin Nation, and I pay my respects to elders past and present and acknowledge and honour the unbroken spiritual, cultural and political connection they've maintained to this unique place for over 2,000 generations. In extending a very warm welcome to everyone in the room, I also want to extend that welcome to the people online. We have a large contingent of online community today, and welcome to you all. This is a hybrid event and people online are essentially participating in a webinar, which makes it difficult to interact, and this is one of the things we have with events these days. It's a bit of a challenge to running an event like this, I think. Recognising that most people here have a caring responsibility, we've kept the day to half a day, and we have a fairly tight schedule, so there'll be limited opportunities to ask questions, but if you do have a question and you can't get it asked, rest assured there'll be plenty of opportunity in coming weeks and months to do that. And I think, Alan, people can put some questions online? Online questions can be placed in the Q&A. So this summit is taking place today because of the dedication of the Summit's Planning Committee, and I want to acknowledge those members right now. Sarah Yates from Caledania Dementia Care, Elizabeth Baxter from Villa Maria Catholic Homes, Deb Farrell, Victoria Hollick and the Dementia Knowledge Network have all worked very hard to make this happen today. Thanks are also due to Ron and De Villiers and his team who are managing all the tech today. So thank you to them as well, who are keeping the people online in the room, as it were. And we're very, very fortunate to have some sector leaders with us here as well. And I want to extend a warm welcome to Professor Amy Brodman, Associate Professor Sam Loy, and Professor Tanya Buchanan, I'm looking for her, there she is, from Dementia Australia. So welcome, it's terrific to have you here. We've also got Luke Campbell, Natalie Ivan, Vicky Barry, who bring their advocacy and extended lived experience to the task we all face of improving outcomes for Australians living with young onset dementia. The Joint Solutions Young Onset Dementia project began because of a big increase in calls for help the Alliance was receiving from stakeholders, family members, health, disability, aged care providers, support coordinators, you name it. We were getting calls for help from everywhere, from people who were looking for the supports and services they needed but couldn't find them. Many people were being sent to hospital for reassessment and the door behind was closed. The provider wouldn't take them back and they faced placement in residential aged care. So we held a round table at the end of 2022 and invited all of those stakeholders to come. We also had senior executives from the Department of Health and Ageing, from the Department of Social Sciences and the NDIA there to hear exactly what people were dealing with. One of the outcomes of that was that it became abundantly clear that family members didn't know where they should look for help and what they should expect to find when they did. So another outcome of that meeting was that the Alliance was tasked with developing a system of care for people living with young onset dementia to be presented to government, and a roadmap of service responsibilities that indicated what you should be looking for and what you should find from particular services along the way. The Joint Solutions project is overseen by a consortium that includes the Eastern Cognitive Disorders Clinic, the Young Onset Dementia Special Interest Group and Dementia Australia. And we're about to hear the results of the project's work to date from some of our consortium colleagues. You'll also hear later from people who are caring for family members living with young onset dementia about what they see as important in driving much needed change, such as choice and co-designing the outcomes they feel are so needed. Clearly, there is a lot of work to be done in this space, and we're very pleased that we've been able to kick-start it and highlight the widespread lack of services that Australians living with young onset dementia and their families need. But first, I'd like to invite to the stage three of our consortium partners, one of whom is online, Professor Amy Brodman and Associate Professor Sam Loy. Would you like to come up? This is a session called Speed Briefing, where I've asked Amy and Sam to briefly talk about some of the outcomes that they've been able to achieve through the project's work. I'd like to introduce Professor Brodman first. Amy is a stroke and cognitive neurologist at the Royal Melbourne Hospital and Eastern Health, and holds honorary appointments at Austin Health, Alfred Health, and the Florey Institute of Neuroscience and Mental Health. She leads the Cognitive Health Initiative at the Central Clinical School, Monash University, and holds professorial appointments at both the University of Melbourne and Monash University. Amy is the recipient of many awards and grants for her work in stroke and dementia, and is the chief investigator on a dementia research team grant. Amy's research focuses on the contributions of vascular risk factors to late life cognition and improving the diagnosis of dementia syndromes. Amy also serves on the board of the Dementia Australia Research Foundation, and in 2020 became one of Dementia Australia's honorary medical advisors. Last but by no means least, Amy is currently part of a national group of experts that's updating the 2016 Clinical Practice Guidelines and Principles of Care for people living with dementia. This work is being undertaken to ensure the guideline recommendations remain at the forefront of care in dementia risk reduction, diagnosis and management. Would you please welcome Amy?
Thank you so much, Bronwyn, and thank you for the invitation to speak today. It really is a pleasure to be able to see you all and have the interest that each of you have. I'm going to acknowledge country as well. Just getting my slides up, I think. Thank you. And also, I think I want to acknowledge Bronwyn. I met her now getting close to 2 years ago or longer. I recognised that steely determination, and I thought this woman is going to do things that we thought were undoable. Lainey and I, who may be speaking today, Lainey Bradley, who many of you know is an occupational therapist with a specialist interest in dementia, have been struggling with many of our patients and trying to get a safe place for them to live, and the successes and achievements of the group so far are quite remarkable. But I'm going to talk about something else today. One of the things, and the reason why it's really great that we're doing this early is so you can all get a chance to look at the QR and actually jot down the website. In Australia, we do have national guidelines on dementia diagnosis and care. Now, that might surprise some people because there's such a different way that you can arrive at the diagnosis. But in 2014, there was a tender that was awarded then to Sydney, and the guidelines were updated in 2016. This process happened again last year, and that the tender was awarded to Monash, and I'm co-leading the diagnosis and care sections, diagnosis and therapies. There's a post-diagnostic section as well as a risk reduction. So I'll go through that and tell you a little bit about what we're doing, and also very much invite you all to have your say in these guidelines. So acknowledging country, acknowledging Bronwyn, I think that the two things go hand in hand. We've got 2 years for these dementia guidelines, and I think that it's great that we're talking about them at the start, talking about what's been achieved so far with the Alliance, and also what's been achieved by this summit. But I think that what I really want to emphasise is that these guidelines need a huge consumer input and voice. And the last guidelines did to some extent, but it was a different world back in 2014. And I think that we really know that the world has changed. We have NDIS now. We did not have NDIS then. So what these guidelines are about is they're NH&MRC, so they're approved by or endorsed by our National the Health and Medical Research Council, which is our biggest sort of endorser of guidelines, and it's about clinical practice and care. It's for people living with dementia, taking into account the most recent evidence, so there's going to be a lot of updates, a lot of systematic reviews as part of this. There's 3 streams which were in the first set of guidelines: risk reduction, diagnosis and therapies, and post-diagnostic care. And all of those are massive and have had huge changes in the last 10 years. So this is integrated knowledge, translation and implementation. It's about implementation. The voices of experience that are involved in this first pass, were involved in the bid and then will be called upon to actually be involved, are obviously people with lived experience. And we've got consumer leads who are actually leading each of these, involved in all this. We've got a consumer advisory group, which is substantial, but I think we still need more members. We've got a lot of advocacy organisations who are involved, and obviously we've got, experts in lived experience and experts in occupation. So we've got people with, from many multidisciplinary backgrounds. Obviously we've got medical people, but we've also got physiotherapists, epidemiologists, pharmacologists, neuropsychologists who are leading different streams. We really think it's important to have these people involved because we need to have the people who change thinking involved in this process. And we also need to have people who are involved in diverse communities. I was just saying to Bronwyn earlier that I've been travelling a lot recently. One of my PhD students is doing a project on the experience of dementia diagnosis in remote communities, particularly in Aboriginal and Torres Strait Islanders. And so we're actually going to have Aboriginal elders from Bourke who are going to be giving us their wisdom as well as doing an art project involved in that to tell us how we should be diagnosing and how we should be thinking about it. And their voices are very, very singular and quite different from others that we've heard. And obviously we need people with translational skills because many of us I'm a clinician, I'm great at seeing patients, but in terms of trying to translate this vast amount of knowledge into different guidelines and strategies, that's a hard thing, and we really need people to support that. So the guidelines are important because the Living with Dementia really the original guidelines only spoke about a couple of types of dementia. They really spoke about Alzheimer's disease, and everyone in this room knows that that's not the only type of dementia there is. We really know that we need to have a really safe pathway, and our pathways aren't safe. I mean, when Lainey and I spoke to Bronwyn the first time, there are unsafe pathways for living with dementia in terms of your health and your well-being. And we also know that the message in terms of risk reduction for dementia is just not getting out there. We go around the country and we talk about brain health and nobody knows anything about it. About heart health, yes. So the Heart Foundation has won this war. And the other massive issue is post-diagnostic care because, again, everyone in this room knows what a nightmare that is and how that, the first year after a diagnosis is obviously grieving and coming to terms with that, and then the next years are grieving and coming to terms with the NDIS. So I think we really do need to grapple with that. We have to look at the whole person in this. I think we do as clinicians, or at least we try to, but I don't think guidelines necessarily do. And also we have to understand what's possible within the constraints of funding and the fact that we are constrained by a government in terms of who they're going to give. At least we're in Australia. We're developing these guidelines. Firstly, we did scoping topics. We've now moved to evidence review for each topic. That's actually a very intensive program that we have to do. That's going to take at least a year for each of these topics. We've got a lot of people on this as well. We'll go to independent review. We go back to public consultation. So the public consultation is back and forth the whole time, and then we publish. And it's really quick. I mean, we got these guidelines earlier this year, and I can't tell you how many meetings we've had to date about this. We're developing the guidelines via grade methodology, which I don't need to go into, but this is a very established method of looking. Tanya's just laughing because it's a big thing. But it's a very established method of looking at scientific but also lived experience. So I think that the advantage of grade methodology, it's not just about what's in the books, because there's not everything in the books, as you know. We're going to consider existing guidelines, the ones that were already published, the ones that are published overseas. There's actually quite a good set of guidelines in the UK, and obviously all of the literature that's currently available. We need to have an evidence to decision framework, and that's going to be done by many of the consultants who are doing and assistants, researchers who are doing this. And then obviously again, it's translation, implementation. You can see how that's going through. We're at the moment, we've collated clinical questions based on the original guidelines and also based on the current international guidelines. We've done an initial exploratory survey of the leadership group, and we're now doing a wider survey of the guideline development group, advisory group and external interest. We had our first public webinar, I think, 2 weeks ago now. I have been travelling a bit, so it's all a bit of a blur. And we've been able to identify duplicate questions, potential questions grouped under different headings, and we've done that into 3 streams. And we're now doing a series of meetings, looking at available knowledge, shortlisting, priority ranking, because there's a lot of new topics. In my area, which is diagnosis and therapies, we now have blood biomarkers and we now have therapies. So we didn't have any of that 10 years ago. The field has changed unrecognisably. It's a different world. So we're reaching out to many of the external consumers and advisors, as well as external international groups. So as I said, 3 streams. The risk reduction stream is headed by Yen Ying Lim, whom some of you might know. She has a public health and neuropsychology background, a big interest in brain health, and she's going to be in her group, which is large, are going to be looking at interventions that reduce your risk of dementia. And this is really important because we do know that there are many modifiable risk factors for dementia. It's what I spend most of my week talking about with people: keeping active, sleeping well, being happy, being social, eating well, and being really active. And did I say being really active is really important? Might have said that. Okay. The stream that Renuka and myself are heading are diagnosis and therapies. This is just so enormous that, in fact, most of the questions for our stream before we said, no, we can't do them all. But essentially, we've narrowed it down to looking at screening tools for dementia diagnosis in primary care, because we need to be empowering our nurse practitioners and our general practitioners to be able to do diagnosis. We just do not have the reach for everyone to come into a public hospital to get a diagnosis, and they don't need to. That's not what happens in most of the world. We need biomarkers for dementia. We've got them. We just have to work out how we're going to implement them now. And the new treatments, which many of you would have heard about in the news, there's new treatments for Alzheimer's disease that may be coming next year, but there's certainly new treatments for frontotemporal dementia that are in the pipeline too. So that's going to be probably by the time these guidelines are published. And driving in dementia, which was a new topic for this stream. We're talking about post-diagnostic care. This is headed by a very large group as well. This is something that we're all talking about today. I've been banging on for a decade about the need to have, a dementia navigator. For once, everyone who gets a diagnosis of dementia will have that person who helps them navigate the system from diagnosis to death. Or to cure, maybe one day, hopefully, just as happens if you have a diagnosis of breast cancer. But we're also talking about supporting independence, we're talking about supporting quality of life, non-drug therapies, pain management, and models of care, of end-of-life care. So what next? I want you all to get this QR code on your phones, and I want you all to have some input. So complete the survey. I can put it up again in the break, but we really want to hear your voices. That's why I was so pleased that Bronwyn asked me to do this, because I usually don't talk about other stuff, but this is great. Don't have to talk about my own work for once. So everyone, please share your voices, because we need to hear, and we need to hear the good and the bad, because believe me, there's a lot of bad. And so I'll put it up again if that didn't work. And thank you. Please register for any updates and get involved. We want all of you.
Thank you, Amy. We've got time for just a couple of questions, so whoever gets their hand up first. No? Margaret.
I just want to know, from a treatment point of view, will LOCL be included?
Yes, oh yeah.
It's only, I'm saying that as a speech pathologist.
I might, yeah.
Sometimes people are referred really late, and it's not of concern, well, it's not on anyone's radar.
I agree.
And we, as a profession, have got big assistance to be given, and intervention and research has proven that, especially PPA and a lot of the
Yep.
we do.
Yes, so Marg, you're absolutely right. I couldn't agree more. Yes, we have speech pathologists, neuropsychologists, occupational therapists and physiotherapists in the groups. We're actually going to evaluate what's published in terms of what's useful as well for non-drug therapies. So that's a big part of the process as well, because one of the things is we don't actually know what works.
Right. Thanks, Amy. Will young onset dementia get a Guernsey?
Oh, absolutely. So,
sure it will with you there.
that was one of the reasons why I sort of have left it fairly open. So, in each of these sections, so I've just got this table, this spreadsheet that I can see in my mind's eye. There is a section that's specifically on young onset dementia, specifically on people from culturally and linguistically diverse backgrounds, people who are First Nations, Aboriginal Torres Strait Islanders, and also people from areas of low health equity as well.
Right, okay. Thank you, that's good to know.
Yes.
Please thank Amy, everybody. That was terrific. It's now my very distinct pleasure to introduce another of the project's consortium partners, Associate Professor Samantha Loy. Sam's a neuropsychiatrist and old age psychiatrist and a Principal Research Fellow at the Department of Psychiatry, University of Melbourne. Sam works clinically with people with young onset neurocognitive disorders, including Huntington's disease, and has multiple research publications and grant funding in the area of young onset dementia, ageing and the mental health of older adults. She's a past chair of the Faculty of Psychiatry of Old Age of the Royal Australian New Zealand College of Psychiatrists, and immediate past chair of the Young Onset Dementia Special Interest Group. Sam's been involved with pro bono work with asylum seekers and refugees and is a firm believer in advocacy and supporting those who are most vulnerable. Sam's also involved in the use of technology to improve and streamline the care of people with dementia and other psychiatric disorders, and developed the Symptom Assessment Manager, which monitors neuropsychiatric symptoms in real time. Please make Sam welcome.
Thank you very much. Thank you, Bronwyn, for having me, and thank you, Amy, for giving that introduction as well. Okay, so I'm going to talk a bit about the background to some of the Joint Solutions project, and this was the project which Bronwyn and her team were able to get some funding from the government as they realised how important it was to get some research and evidence behind all the difficulties that you are all experiencing as people living with young onset dementia and caregivers, and also as clinicians. We are also seeing it. And what we wanted to do was try and actually get some evidence from some research data to then be able to lobby further to get some improvements in this area. But first of all, a background to that project, which my colleague Claire will be talking about, is we wanted to do a literature review to look at the models of care all around internationally and also Australia, looking at young onset dementia. This was run by my colleague, Associate Professor Nathan DeCuna, and his team at the University of Canberra. So I'm going to be presenting his work, so I'll try my best to present their 6 months of literature in this short time frame. Okay. So this is looking at young onset dementia models and trying to think about what we find out in our research and whether we can try and integrate that from what's been seen in the literature around the world and see how we can marry them and see what can work well for people living in Australia. So very quickly, I won't bang on too much about that, about what young onset dementia is, but you can see the really important epidemiological statistics in the graph below. Currently estimated to be 28,000 people living with young onset dementia. That's probably a underestimate. There's a various different sort of frequencies in the various states of Australia, and also the estimated prevalence in about 30 years' time. And some states, for example, will be increasing to 40 to 50%, particularly in Victoria, New South Wales and Queensland. And so this is thinking about what we need to think about for the future for people with young onset dementia. So looking at the different models and the components which may be required, particularly for people with young onset dementia, this also would go along with people with older onset dementia. But central to this would be the person-centred care. So looking at individualised care for the person with young onset dementia and their families, but also thinking about around the circle about their medical health, particularly because of the stage of life, employment and financial problems, relationship and family issues, younger children often, and particularly maybe even ageing parents. And as we all know, it's about trying to navigate the system, so thinking about that sort of navigator or case manager, but also things such as the post-diagnostic support, but also how can we learn from the literature internationally about training for people who work in the sector, who know about young onset dementia, and trying to increase their knowledge about what young onset dementia is about. We do know it's quite different from older onset dementia. This is just a little bit more detail about some of the components which has been described in the literature, and I'll talk about some of the models of care which Nathan and his team found, which contain some of these components. And Amy's already touched a little bit on this. For example, care coordination, so having someone who can help navigate the person throughout from post-diagnostic all the way to end of life. We do know that there's some differences around Australia in itself and even in regional areas about the different care pathways, and that can add to the difficulty in trying to get a diagnosis, but then also what happens afterwards. There's a lot of differences around Australia and the world. How do we integrate social care, medical care and physical health into these models? And as I'll touch a little bit upon as well, sort of the end-of-life type discussions. There's also the memory and specialised clinics, of which some of us may be involved with, and also supportive care components, which is the sort of biopsychosocial aspects of living with young onset dementia. Okay. So this is, again, not new to any of you, but obviously in young onset dementia, there's some very specific components which are quite different from people who are older. I've already talked a little about the sort of the financial and employment issues, but the sort of lack of age-specific services. So we do know that if you are trying to get education or perhaps join a support group, often they may be more geared towards people who have older onset dementia, and so sometimes the discussions which people may be involved with may not be particularly relevant, or people want to know more about, for example, how do I tell my child or my teenager what's going on with my husband, for example. Those discussions may not come out, for example, in those older onset type groups. And there's obviously things about family, all the different dynamics, trying to navigate the change in the relationship from being a partner, from then becoming a carer, and how do we go about that and how can that be discussed more openly? And obviously on a much broader issue, which I think does go for all people with dementia, how do we make our communities more dementia friendly and acceptable and try and decrease stigma? So in this particular rapid review, Nathan and his team had a couple of months to really trawl through the literature and try and find out what was out there. And they called this a rapid review. I won't go into the sort of specifics of that, but they looked through, over, many years worth of literature all around the world and trawled through the abstracts and tried to find out what was relevant in terms of young onset dementia. They were really looking at young onset dementia in terms of the primary dementias like Alzheimer's disease and frontotemporal dementia, as opposed to the dementias which might result from, say, multiple sclerosis or HIV. So really sort of targeting those types of dementia. and they were able to find 19 peer-reviewed studies and 11 articles from guidelines from peer-reviewed literature, and also they did find a whole lot of interesting dementia action plans from countries internationally. So I'll talk a little bit about those. So it was quite encouraging to see that there were quite a few countries who do have young onset dementia included in their national guidelines and action plans. You can see Australia has that listed there, and obviously Amy and the team will be updating that for the next decade. But there's a whole lot of different, every country has their own idea where YOD should fit. So for example, Denmark has a particular specification, like 80% of people should be involved in specialist clinics, for example. And some of them are more detailed than others. I'll talk about some of the really interesting types of guidelines a little bit later in this talk. So the main types of models of care Nathan and his team found really were divided up into these three main categories. So they divided them up into, say, system-level models, which was a broader national frameworks and guidelines. Then they looked at the specialist services and memory clinic models, which were often delivered in a multidisciplinary team or within a hospital or university type service. And then they looked at supportive models of care, so that sort of post-diagnostic type stuff. Okay. So this is quite interesting. I was really quite it's good to think about what you can learn from other countries. So there's some countries which are really leading the way in terms of guidelines and frameworks for young onset dementia, and some of the things which they looked at particularly was Japan and the Netherlands. So these two countries are really looking at inclusion of young onset dementia in their broader national dementia guidelines, but then also specifically looking at what's really needed. So some of the stuff which we all know, so the lack of navigation, the difficulties in trying to get post-diagnostic care, which is individualised and age-specific. Japan and Netherlands, for example. Japan, which we had before in Australia, they have a care navigator, for example. So there's someone who is there on the telephone to help guide the person throughout their journey for young onset dementia, and that's been really importantly picked up. The Netherlands, for example, they have a young onset dementia knowledge centre, which is actually funded by the government. And with this knowledge centre, all the different universities are attached, and then they try to integrate guidelines and projects and the updated types of care, which then can flow from this dementia centre all the way throughout the country. I was also very impressed that I spoke to one of the leaders in the field, and he said, we've only got about 20 young onset dementia accommodation services. And I was blown away, because that's, much better than what we have, for example, in many parts of Australia. And he was sort of saying, we've only got 19 and we need more. I think the Netherlands is really leading the way. Obviously, you can think geographically it's a little bit different from Australia. They're much smaller, so it's a bit easier to implement these types of processes, but they've really worked hard to get this knowledge centre, and the government, for example, gives them money every year to try and for them to allocate funding for research projects. So it's a really good example where everyone's working together to try and improve the care and quality of life for people with young onset dementia. Some of the other places which are really also leading the way is the UK. They've got the Young Dementia Network. They've got a lot of guidelines and frameworks in how to navigate the pathway. This little figure here on the side is what Ireland, for example, they've got a really clear pathway of what happens. You probably can't see that. I can see everyone squinting, and I can't see very well either. But we can perhaps share the sort of references, but it really shows the pathways of care and guidelines of what GP should be doing. So, for example, history taking, neurological examination, some basic cognitive tests, and then moving on to the service which should be taking them on next, such as a cognitive neurology service or a memory clinic or a regional memory service, and then what happens next. And so something like that could help a GP to think about where they should go if they are thinking about young onset dementia. And I guess the challenge in Australia is it's very different across the different states and territories and regional areas. So how do we manage that within such a large country? This is just a little bit about integrated and memory clinic models, where, for example, already developed memory clinics, for example, within Australia or the UK, they are able to integrate young onset dementia within that particular service. So whether it's about a particular person who's skilled up in young onset dementia, so then if there's a referral which comes in, they then get moved and triaged to this particular expert in the area. And for example, in the Royal Melbourne Hospital, we've tried to create a young onset dementia clinic, and I think similarly with the ECDC model as well, where we have particular networks. We work really hard to try and funnel people towards the right direction and do a one-stop shop. so people can get their diagnosis done as quickly as possible without trying to repeat their history or repeat investigations or go through unnecessary investigations. I'll just list some of those here. So we have the Melbourne Young Onset Dementia Clinic, which is a dedicated service. We worked quite hard with Dementia Australia and quite a few service providers to try and give more care for people under 65. And from this Young Onset Dementia Clinic, we're able to get funding, which my colleague here, she helped run what we call the Bright Yod Clinic. So thinking about the disparities in rural regional service, for example, in Victoria, they take a lot longer to come to specialist services. So that particular funding project was able to work very hard with Albury-Wodonga, Shepparton and other rural services to try and improve the diagnostic delay and have access to telehealth. And this was happening in 2018, 2017, so pre-COVID. So they really kind of helped to kickstart that you could actually do things via telehealth and it could work. And that's had some really good sort of work and evaluation done by some colleagues as listed below. As I mentioned before, the UK is very good at developing and integrating young onset dementia within their current memory clinic services or mental health services, but it really is location specific. So it depends again on where you live. There's a few good examples I've listed there below. They do try to expedite diagnosis and try to integrate post-diagnostic care for people with young onset dementia. A few other examples in the United States, again the Care Centre, Care D, the Jockey Club in Hong Kong, again a specific young onset dementia or early onset dementia service where it helps to upskill carers, provide support groups and activities for people with young onset dementia and support their carers. And the Care Ecosystem in San Francisco, which is a fantastic model, very similar to the Yod Care Worker program, which we had in Australia, but a little bit more, I guess, financially viable and able to be, I guess, brought out and spread out throughout a lot of a big area. So that's something which I think is a really interesting example which could be done, for example, within Australia. And just very quickly, these are some of the supportive care models of which has been described in the literature as well, where it's about the post-diagnostic support, so activities for the person with young onset dementia which are appropriate, but also providing support for their caregivers and perhaps even training or the provision of education to service providers, which is very important. A few examples here in Wales, the ACE Club, where it's a particular day program and respite. So we know that sometimes NDIS might give you 2 hours a day. That is not, in my opinion, particularly feasible if you're a carer. You don't get to do a lot in that 2 hours, let alone even work, for example. So a day program or respite can give perhaps opportunities for a caregiver to do other things and actually give them the time to do these things. England, the Peaceful Place Essex, again, a collaboration for community programs, day respite and meaningful activity. I think Sarah Yates or Elizabeth, they do a lot of these things in Caledonian, which is excellent. And in Birmingham, this is an interesting model of care where they've worked with a financial and employment agency to actually try and deliver that particular support and advocacy for people with young onset dementia and their carers. Okay, this is just about some ideas about enhanced approaches, what we could learn in Australia. So some of these previous things described in the literature talk about guidelines and referral pathways. Perhaps these are things we should be doing more so in Australia. Some of the ideas which I guess thinking about the project from what we've learned from the joint solutions is how we can learn from a hub and spoke model. So that, for example, the Bright Yod project had the hub being, for example, at the Royal Melbourne and the different spokes around providing the services, but then being able to tap into expertise in the area and knowledge as well. So that could be quite something we could roll out, for example, in Australia. And I guess the other really important thing is how can we collaborate with community to try and provide the programs more so which are appropriate for people with young onset dementia. Okay, and that's just a bit more sort of, thoughts about, workplace, try to support people in their employment, financial capacity, and thinking about how can we support the family, what models of care out there. Dementia Australia has their family services as well, but perhaps there should be more. I don't think they can manage everybody who's got children, for example, who might need counselling and that kind of support. Okay, so just going to close here. A lot of the models which were described in the literature, they were special projects which were funded, and once the funding is stopped, then the difficulty lies, well, what happens next? How can you keep these models which have perhaps worked, or how can we learn on them to try and create sustainability so these models can continue? The other thing which I mentioned is that there's only a little bit written in the literature about employment and financial help, and obviously lack of family-based services. There is a big lack in the literature about end-of-life care and palliative care, and Claire will talk a bit about that from our findings as well. And then just some implications, learning about what we can do for the future in Australia is that a lot of these projects and really good models of care were very location specific. So many of them were located in major cities, and we do know that in Australia people are really living throughout Australia. So how can we try and create some kind of model for people who are living rurally and remotely, and also for culturally, linguistic, diverse and Aboriginal Australians. And also some of these models were funded or supported by hospital and universities. So that, again, how can we continue that or get funding for those things? And just some things to think about, and it's good that Amy came and spoke about guidelines. So how can we think about guidelines and referral pathways? How can we generalise these across Australia where it's very different in terms of equity of care? The other thing which is we didn't see a lot in the literature was about education and training for people who are care providers or wanting to know more about young onset dementia. And I guess the other thing is about how can we make our community a lot more dementia friendly. So I'll just close there.
Thank you, Sam.
Thanks.
A couple of questions? Okay. We've got time for a couple of questions. Yes, Tracy.
I think the biggest challenge for us is that our NDIS coordinator is my go-to person.
Yep.
And I do feel that there's a limit. Sorry, I don't like these things. I do feel that there's actually a limitation when we are referring to those people. As a full-time mum that is working, does a lot of travel, and have no family here to support me, that I find that I get so confused by, well, where do I go to next? And the NDIS coordinator to me should be that person. But I don't feel that they actually necessarily have the right tools, the qualifications, the expertise, whatever that looks like. And that's been my biggest challenge. Because otherwise I'm going, well, where do I go to next? The GP tells me one thing, then I go to a physio and I'm constantly getting different messages. And that doesn't help me with my stress levels because it then impacts on my partner who has the dementia. So I'm wondering what you're doing in that space.
Yeah, that's a really good question. I think that's been seen when I talk to families and people with dementia, and also in my experience as a clinician, I'm supposed to be knowing about all these services, but I don't. And so that's why we're really advocating for someone like a navigator who knows what's going on in each particular part of, for example, Australia, who is in touch with the services which are out there, so they can help guide people like yourself who are busy and cannot spend hours on the phone ringing up people and sort of checking the website. And so some of the project findings, which Claire will talk about next, is trying to think about how can we make that navigation easier. Because the other thing is that it's also very hard to know how much information do you give. So everyone is very different. As a clinician, you want to say everything, but you can't, because the person on the receiving end can only take in so much. And so there needs to be a way that people like yourself can then go to somewhere, whether it's a person or a website or a resource. And even the NDIS people, obviously it'd be great to upskill them, but that's another sort of issue which I'm not really part of. But if they also knew that there were these resources available, then they could also say, hey, why don't you go there? So it's a bit of a triple-pronged approach, I think. But we do hear that it's... Yes. Yep. No, absolutely. I feel what you're saying.
Thanks, Tracy. I think that's one of the things the project is going to do, to develop this roadmap of service responsibility that should help, which will need to be kept updated, I guess, too. But the navigator's a very important part of that as well.
Can I just say something there in relation to the navigation?
Yes.
I don't know if everyone's heard of My Dementia Companion, but I'm here representing Nan, who spent 4 years of his life trying to help families in that situation. And that's exactly what it does. So it directs people, uses a bit of AI to customise the information and direct you in any state you live. And there's an enormous amount of resources, and they're customised and they come up at relevant times. So I just wanted to mention that. We can
Thank you.
Yes, that's absolutely, and we've mentioned that in our project findings.
It's your personal navigator, isn't it?
Well, that's right. It's just saying that there are things which are existing and we should be able to use them. Why would you reinvent the wheel? So, for example, we've obviously mentioned My Dementia Companion for particular sort of as a resource. So thank you.
Thank you. Please thank Sam. It's now my pleasure to introduce the last of our speed briefing speakers, Dr. Claire Beard. Claire's part of the Summit's online community today. She's on holiday in England, so we're very grateful to her for making the time in the middle of the night to do this. And she's going to be talking about the outcomes of surveys and focus groups the project's undertaken. Claire's an early career researcher specialising in young onset dementia, with a keen focus on vulnerable and minority populations. Based at Flinders University, Claire's PhD examined modifiable risk factors for dementia in people experiencing homelessness, including barriers to cognitive wellbeing and dementia risk reduction. Her research emphasised the critical role of stable housing in mitigating dementia risk through a social determinant lens. Claire has considerable experience in health, including roles with Dementia Australia, and has worked extensively with people experiencing young onset dementia, culturally diverse groups, and those facing housing challenges. Please make Claire welcome, and fingers crossed we've got the link.
Yes.
Thank you very much, Bronwyn. So as Bronwyn said, I'm Claire Beard and I'm one of the researchers for the Joint Solutions project. And we were tasked with understanding the gaps, barriers and positives in the young onset dementia care pathway. So to do this, we took a mixed methods approach to this research. First, we gathered quantitative data from nationally distributed surveys, and that was across 4 stakeholder groups, those being people living with YOD, their caregivers, clinicians and GPs, and community service providers. And we also gathered qualitative data, which came from the free text survey comments and from 10 focus groups. In terms of the demographics, we had a total of 313 participants, which consisted of 33 people living with YOD, 105 caregivers, 93 clinicians and GPs.
Claire?
And 82, yes?
Sorry, did you want to share any slides? It's Sam here.
Oh, yes, it is showing this way as...
We're doing so well. I know you've got some really beautiful slides. I don't know whether the technology, is it easier for you to share? Would you like our IT to help share?
Yes.
What do you think? Sorry.
Okay. That's okay. I'll just see if I can...
Maybe because she's a
come on
webinar.
and share this way.
Let's see.
Nope, that's not that one.
Depends, because if you're a webinar participant, you might not be able to share. I don't know.
Yes, it does say.
Okay.
Share screen 2. Okay.
Okay.
Are you able to see that?
Not yet.
Can the tech people do anything down the back? No. Oh, you've got it? Right. Thank you. I think we're getting it together from this end.
Okay.
No, that's still not sharing, obviously.
Here we go. I think something's happening. Thank you. There we go. Thank you, Claire. Thank you so much. I'm so sorry that.
Oh, no problem at all. I'm sorry that took a moment to do that. So yeah.
Do you want a slideshow?
Yes.
Just because then we can see you as well.
Okay.
All
Right. I will continue from
Thank
where
you.
I was.
Thank you very much.
Okay, thank you. So I'd actually just got up to this slide, which was in terms of the demographics. We had a total of 313 participants, which consisted of 33 people living with YOD, 105 caregivers, 93 clinicians and GPs, and 82 community service providers. Nearly 3/4 were female and more than 90% were Caucasian. 32% lived in non-metropolitan areas. And if you look at the map, you can see that we had representation across all states and territories, with the highest number of participants coming from Victoria. So I'm just briefly going to present some of the highlights from the project findings. We found that half of our caregivers reported that the process to diagnosis was not smooth, with only 50% of people reporting that their GP was aware of what YOD was. And getting that referral and access to specialist diagnostic services could be a really lengthy process for some. However, once a person was linked to a specialist diagnostic service, then things became pretty straightforward, with many of our participants being diagnosed within that 12-month period. We also found that it was challenging for GPs to recognise that a YOD process may be occurring, and that there are issues with the availability, timeliness, cost and invasiveness of tests. And we found that the low public awareness of YOD can affect people who can easily dismiss their symptoms and therefore delay seeing a GP. The mean age of when symptoms were first diagnosed was 56 years and 58 years for being diagnosed. And it was often a balance to provide an early diagnosis with an accurate diagnosis. 43% of our participants were given other diagnoses prior to that of YOD, which were mostly mental health or other neurological. And this really resulted then in multiple follow-up appointments to review that diagnosis. And many people found this to be a frustrating process. The diagnostic experience was contingent on the amount of information being provided and the clarity of that information. And if the diagnosis was given sensitively and supportively. As one person said, "We received the diagnosis. In the same meeting, husband was told he must give up work and driving, and as we left, we were handed a pamphlet about brain donation." Another described their experience of receiving the diagnosis as, "I was simply told I had frontotemporal dementia. Bugger off and come back next year." We also found that some clinicians may lack understanding of the genetic underpinnings of YOD, and without a guide for when or how to make referrals, this could lead to missed opportunities for genetic testing and counselling. We observed that different individuals require different information at various time points, so therefore the system needs to be really flexible. We found ways of modifying dementia risk factors were routinely being discussed, and that most of people were being informed of key dementia services such as Dementia Australia, Forward with Dementia, or the Carer Gateway. However, there was a lack of post-diagnostic follow-up appointments, and people felt unsure where to go for support, with clinicians also being unsure as to where to refer them to. Collectively, these experiences led to a system of fragmented care. Many people with YOD were not offered services including cognitive rehabilitation, allied health input, and peer support. But where they were accessed and utilised, people tended to have good experiences of those services. However, supports must need to be able to keep up with the disease progression. We found that support workers were highly engaged and wanted to improve their YOD expertise, and that family members found Dementia Support Australia helpful for behavioural support. There was geographical inequity in post-diagnostic care and limited availability of services such as psychological support for carers, and it was also hard to find allied health professionals trained in YOD. Furthermore, most services were not suitable to the person's younger age or time of life. Overall, people acknowledged that the concept of the NDIS is excellent, but reported problems when applying to access the NDIS, which they generally found to be cumbersome and difficult. Many people found it hard to navigate, with limited assistance being available to them. And they felt that it was generally disjointed and sometimes had really long wait times. As one person said, "I am a highly educated person, a former public servant and a teacher with many years of admin experience. The plethora of forms required and the inflexible online applications have beaten me." Psychosocial interventions and advocacy are important supports for family and friends who need better access to these services, and they often have really high levels of carer burden. The lack of services is a problem because, as one service provider said, we're educating carers to say, you need a break, please look after yourself so you can continue to care. And there's nothing apart from perhaps someone coming into the home for 3 or 4 days. And peer supports are highly regarded. Most often people want to be able to connect to others who are in the same boat. However, we did find that some people found peer support to be too confronting. Most of our lived experience participants had children living with them at some point, but only 12% of them received support for their children. And when it comes to advanced care and future planning, timing is important. And most agreed that the topic should be raised early while the person has capacity to make decisions. Differences in when to make driving notifications was evident, with some clinicians leaving it up to the person or their caregiver, while others made notifications immediately. And there are a few examples of good housing and respite models, which are well staffed with people trained in yard. However, not everyone was ready to discuss advanced care and future planning immediately following the diagnosis. Additionally, many clinicians considered the provision of financial advice to be out of their scope of practice, and generally there was a lack of alternative transport and overall limited options that were available for age-appropriate accommodation. Importantly, our research has led to 8 recommendations for a gold standard pathway of care. Our first recommendation is for a key person to support, inform, and help navigate services from the point of diagnosis. The second recommendation is for streamlined services that anyone can access, regardless of where they live. A national directory of YOD services would be really helpful for this. And also a hub and spoke model for regional, rural, and remote health areas should be developed. Our third recommendation is for a dedicated YOD website as a centralised system or hub. The fourth recommendation is to improve communication and collaboration, to set up a confidential portal for families and professionals to access care notes and letters or other forms of communication. Our fifth recommendation is for more individualised support, assistance when accessing the NDIS and other supports to meet physical, psychological and social needs. Our sixth recommendation is to improve access to day programmes, respite care and age-appropriate accommodation with YOD-trained staff. The seventh recommendation is to improve access to diagnostic and post-diagnostic services for diverse groups. And our eighth final recommendation is to increase public awareness of YOD and tackle stigma. Our research had some limitations. So, for example, there were unequal representation across the states and territories. There was underrepresentation of secondary dementias, for example, MS, HIV, intellectual disability or Down syndrome. We had no representation from hard-to-reach groups, such as people experiencing homelessness, people who are incarcerated in prisons or forensic institutions. And we had limited diversity. For example, we wanted to hear more from First Nation peoples, from culturally and linguistically diverse communities and other ethnic minority groups, the LGBTIQA+ communities. And despite our best efforts, we only had a small sample of GP respondents and a small sample of caregivers whose loved one is in the advanced stages of dementia or has died. And that brings me to the final slide of this, and to thank you very much for listening. And I'll stop the slide share now.
Claire, are you happy to take a couple of questions?
Yes, I can, yes.
If there's anyone with a question. No? I think we're all... Oh, yes.
Sorry, I worked at Dementia Australia for many years and I was aware they had a dedicated YOD website. And so I just wondered, was that adequate or not?
Oh, did they?
Tanya?
They've got the hub.
Tanya Buchanan, everybody, CEO of Dementia Australia.
Hello everyone. It's lovely to be here and lovely to meet you all. And so anything I say now, please take within the context of I've been here 5 months. And I have heard a lot while I've been getting around and talking to people about the Younger Onset Dementia Key Worker Program and how well received it was, and the funding that came to Dementia Australia for that predated the NDIS. And so when NDIS was established, that funding disappeared. And so one of the things that, since I've been here in the last 5 months and working with the team internally and also with our dementia advocates, so it's lovely to have Natalie here as well, is talking about what are our priorities over the next term of government. And unsurprisingly, navigation is right up there, and ensuring that we have a navigation through NDIS and for older Australians who have dementia, so recognising that we need both. The other thing that we have also been looking at is changing the way we deliver our services so that we were previously quite siloed. You know, you would do this service and then maybe you do this service, and so taking that navigation approach ourselves. So we've just kicked that off, I think, this month. So we've been hearing it as well and trying to do some changes, but we are very strongly pursuing Minister Shorten while he remains in office and his team around the need for navigation in NDIS. And the only other thing I'll pick up on very quickly, because I think it relates to the conversation earlier about dementia-friendly communities, is that for the next 3 years, the term of the next government, we're going to be focusing on pushing local governments in particular to pick up dementia-inclusive communities and really be reporting on the progress on that too. So I'll shush now. So hopefully that answered that question.
Thank you, Tanya, and I suppose the thing I'd say is watch this space. Thank you, everybody, for your patience. I know we're getting a bit close to time, but would you please thank our speakers so far? Can I call our next group to the stage? Craig and where's Natalie? And Julie? Where's Julie? There she is. Come and have a seat. Now, I don't know who's got the microphones. Who's got the microphones? Oh, no, it's okay, Sam. We're going to use 2 microphones. Come on up. You right to get up there? Good on you. Good on you. Have a seat, Julie. And there's 2 microphones there.
Can I ask you a quick question?
Yes.
When it comes to returns of my question, can I speak?
Yes, of course you can, yeah. Right, so our next session is called Walk in My Shoes, which will be familiar to many people in this room, that term. At a recent exhibition of art done by people living with young onset dementia in Western Australia, this very insightful comment was made. Everyone's story becomes someone else's guidebook. This session, Walk in My Shoes, will give you the opportunity to learn from the lived experience of others. And I'd like you to welcome our panel, Natalie Ive, Julie Di Napoli and Craig McDonald. Natalie, if I can start with you first, and I'll get you to come up here when you want to answer. First of all, thank you for sharing your experiences with us today. You're an experienced educator. You have a Master's in Special Education, a dual award degree in Political Science and extensive experience in both mainstream and special education settings that span more than 15 years. You're on Dementia Australia's Advisory Committee and you're a member of the Board of Directors for the Australian Aphasia Association. You advocate for all people living with dementia and you've been involved in guiding multiple research projects, most recently co-authoring the Primary Progressive Aphasia Guide with key researchers and clinicians in the field. I want to ask you about employers and employment. when you've been diagnosed with a dementia. We need employers to be supportive of an employee diagnosed with younger onset dementia so they can maintain their employment as much as possible. What are your thoughts on this? Come on up. Now, you'll need one of these. There you go. It's not on. Do you want to hold that?
Okay. Thank you, Bronwyn. Excellent question. So I strongly believe that creating an inclusive workplace culture is vital for supporting employees living with young onset dementia. This creates an environment where diversity is celebrated and all employees feel respected and included. Promoting awareness and understanding about dementia among all staff members can help reduce stigma and encourage empathy, making it easier for dementia employees to seek help and share their experiences. Next, employers should provide accommodations to support those with younger onset dementia effectively. These are my suggestions you might like to consider. Flexible working hours, allowing adjusted schedules to accommodate medical appointments or taking more regular breaks, allowing for energy levels can help manage symptoms significantly. Job modifications, adjusting job responsibilities or expectations can help employees continue to contribute meaningfully. Access to resources and support. Employers to utilise the valuable resources on the Dementia Australia website. By doing so, they can tap into an extensive array of information that equips them with the necessary tools to support employees facing the challenges of young onset dementia effectively. This proactive approach benefits the employees and fosters a more inclusive workplace environment. In conclusion, I firmly believe that fostering dementia-friendly communities is a crucial step forward. This initiative requires government support at all levels, including local councils, policymakers, businesses and community associations. By working together, we can create an environment that supports people with younger onset dementia. Such an inclusive approach will empower people living with younger onset dementia to continue participating in the workplace and contributing to their community, ultimately allowing them to find a sense of purpose and fulfilment, much like any other member of society. Thank you.
Well done. If that wasn't a call to action, I don't know what is, so I hope you all heard that loud and clear. Julie, if I can hand you that without knocking Natalie on the head there. Wanted to come to you now. One of the recurring themes in the consultations and the conversations we've been having is about respite and the chronic lack of respite options. And I wanted to ask you what your experience has been and how this has impacted you and your husband, Frank.
Sorry? Oh,
Yeah, we're on.
It's actually impacted us greatly. We have been on this journey for over 9 years, and in that time, and we've looked, and many other people that I know have also looked, at finding suitable respite for our loved ones. There are respite facilities, but none of them cater to young onset dementia people.
Right.
My husband is still what they would consider pretty active and pretty, or in some ways self-sufficient. So he needs to be engaged
at that level.
He needs things to do. So in looking around at what was available, if he was to be placed in normal respite facilities, I am convinced it would be detrimental to him.
Right.
Therefore, there'd be no point in me having time out because I'd be worried about him the whole time and what have I done to him? And I realise my take on this is totally emotional, and which is exactly where I should be. I'm caring for a husband that I consider now to have lost to the larger degree, and he deserves to be cared for in a way that he needs, not in a way that he doesn't fit into any of the pigeonholes that are out there at the moment.
Right. So we've heard from Natalie talking about inclusive communities. I think respite options that can cater for people with young onset dementia is also part of the call we need to make.
Absolutely.
Yeah.
And it's a way for them to still feel, I guess, validated in the community.
Yes, and engaged.
Engaged, feeling like they still have a place, like they can still contribute, they can still share. My husband, for one, is a great storyteller. Whether the story is true or not doesn't really matter. No, and I'm often privy to a lot of his stories, and unless what he is saying will impact on anybody or be harmful to someone, or I just say nothing. Yeah. And people around enjoy the stories and they take it as gospel, and that's okay.
That's fine.
Yeah.
That's right. Thanks, Julie. No, I think you've made a really important point there, that it's not only residential services that we need that are specialists for people with young onset dementia, but definitely respite options as well. Great. Thank you. Give Julie a hand. Craig, I'm going to turn to you because you're up here too. You're in the hot seat.
Thank you.
You've done extensive training as a dementia care nurse, and you've also worked in health and community services management. Do you think this sort of background prepares you for someone you love being diagnosed with young onset dementia?
Unfortunately, Bron, I don't think anything really prepares you for this. My background was in diversional therapy and also as a nurse, and I'd been involved in setting up some, actually a younger onset dementia respite facility about 10 years ago down in Rosebud that Alfred Health at the time were utilising. But nothing can actually prepare you for it. And the pre-diagnosis period, getting to an actual diagnosis was difficult when you have my wife was a naturopath and remedial therapist, and so she was always, I guess, fairly sceptical about Western medicine models.
Right.
So that made bringing her, I'd obviously seen some signs and symptoms, and I suspected what was happening, but I thought maybe I'm jumping at shadows here. But she was eventually misdiagnosed, as many people are, I believe, with anxiety and depression, and she presented with emotional lability as well in the GP's office, and there were question marks about, you know, whether she was potentially being abused by her partner. That came up as well. And it took us a good 18 months before we actually got to diagnosis, even though I'd been really pushing my wife to get to that point. So there is resistiveness, I think, out there in the community. And people, obviously, they don't want, they're fearing the worst. They don't want to know that diagnosis as well at times. So that was very challenging. Once we actually proceeded to the diagnosis, that was a very smooth, fairly smooth procedure.
Right. And another question I want to ask you, I mean, I think that's really important to understand the pre-diagnosis difficulty people go through, and sometimes are given medications for this misdiagnosis that can aggravate the dementia. But I wanted to ask you about families. One of the things that someone living with dementia said to me in one of the many conversations we've been having is that we don't come alone. We come with a family attached. And yet our focus on person-centred care, which is terrific, tends to forget about the family and the children often who are part of that family. Do you have some thoughts on that?
I do. I mean, I think those statistics that YODSIG, the project, found that you've got 52% of people living with younger dementia have minors that are living with them, and only 12% of those minors or children are actually receiving assistance.
Yes.
In my case, Dementia Australia were fantastic when we were put in contact with them. I received counselling and I tried to bring my daughters along with me, but the situation was so raw for them. I have a 14-year-old and a 17-year-old, and they were 11 and 14 at the time of diagnosis. So very difficult to bring your children along because they're going through a whole range of emotions themselves, and they basically wanted to put their heads into the sand,
Yes.
understandably through the COVID period as well. They'd been isolating in their rooms. I'd been going off to work in a hospital environment, leaving, you know, my wife basically pre-diagnosis with my children, and I was just thinking everything's going haywire here. There's no schooling happening here, and so there were just so many gaps there. I just think that it's really important with children that they receive the support that's so important for them.
But at a timely.
Yeah, look, I think
point.
one of the issues, you know, I think the NDIS is absolutely fantastic, but in terms of children, it's very difficult because we're all taught when we're studying in healthcare and nursing courses, etc., the kit would model the person-centred care. So the person who's living with dementia, they are the primary focus. But when you're talking about a wider family circle where you've got a partner who's working full-time as well, the children seem to be collateral damage in that situation.
Indeed. And has that been the case with your family?
Unfortunately, yes. Part of it's to do with the family dynamic and my children not necessarily being open to the counselling. I've got a younger daughter, 14-year-old, who now has depression and anxiety, and a lot of that is stemming from that. I mean, I recently sought feedback from my 14-year-old to put together an impact statement to forward to the NDIA in support of getting additional funding. I could read part of that for you, and it would probably give, if you'll indulge me for a minute.
Absolutely. I think that's very important.
So from my 14-year-old daughter, I can't remember what mum used to be like. It makes me sad all the time because everyone else has a mum. Mum used to look after me, but now I must look after her when I want to do fun things. She rolls her eyes when I try to help. I don't like having her at my performances when I would love to because she starts crying and getting upset. It makes me depressed because I think she's going to die soon and she won't be able to live with us much longer. We can't do many things as a family anymore because of it, and it makes me sad. I'm worried when we're the only ones at home because if I forget to check on mum, she might walk away. I hate being at home sometimes because seeing her like that makes me cry, and I hate it. I'm the youngest, but I'm the one that has to take care of mum when no one's home, and I have to answer all of the questions from the carers. So it's very challenging for children. I've tried to keep our family environment as normal as possible so that when I go to work, that's when the carers come through, the girls are at school. We're now moving into the next phase where we're starting to, at this stage I'm doing all of the personal activities of daily living, assisting with showering, etc. in the morning, but we're moving into the next phase, which is great that we're receiving additional assistance, but it means that now we have all of these, a whole range of carers coming in for more hours through our environment into a small home. So we need to look at those residential options.
Yes.
You know, I'm wanting to explore using my wife's massage studio, converting it into a granny flat so that we can, you know, potentially have, you know, my wife eventually going
Her space.
overnight. She's safe in that area, and then during the day she can come into our home environment with the regular carers. I'm not looking to put my wife into residential care at all, but I recognise that in the long run it will potentially be my daughters, my children who are affected.
Yes.
They will have more difficulty living with that and coping than I will because of my experience.
Thank you, Craig. I think that's very telling and amazing that your daughter was able to be so articulate about what's a horrible situation. But again, I think it's a very timely reminder of the fact that while the person with dementia might be getting care and support, it's a total disruption to the family space, the family home, and that's a hard thing to deal with for many people as well. Thank you very much for sharing that, Craig. Please thank our panel. I think you give them an extra hand for that because that was fantastic. Please thank our panel. I know we're running a little over time, but I think it's been worthwhile. We've got morning tea now, and I'm not quite sure. Can someone tell me what the time is? I don't have a watch. 11th. Oh, we're really almost on time. Okay. Morning tea is outside. We've got 20 minutes. We'll be starting on the dot. So grab a coffee and whatever else is out there and come back in. And thank you for being such a terrific audience so far. See you in 20 minutes. Okay, everybody, if you could take your seats. Some terrific conversations over morning tea, and more are possible when we break for lunch after this. There'll be a real opportunity to continue those conversations then. It's my pleasure, I'm saying that a lot today, but it really is my pleasure, to introduce to you Vicky Barry. Vicky is the founder and facilitator of the Young Dementia Network WA that she established in 2016. This is a network that provides peer support for people living with young onset dementia, their care partners and families. Vicky was also instrumental in the creation of Yodyssey, the art of doing well with young onset dementia, via an annual art exhibition showcasing the work of people living with young onset dementia to raise awareness in the community. And that quote I read out before was from the Yodyssey exhibition last week. Vicky is a staunch dementia advocate for Alzheimer's WA and Dementia Australia. She sits on many advisory and working groups to inform and influence better outcomes for people living with young onset dementia, their care partners and their families. Vicky is a care partner herself and has been supporting her husband who's been living with young onset dementia for the past 12 years. Please welcome Vicky, who's going to introduce you to someone else.
Thanks, Bron, and what a joy it is to be here with you all today, so all the way from WA. So yes, I'm going to be introducing the next speaker, who I've got to say unashamedly, I'm a huge fan and follower. So real privilege. Tessa Gutteridge is the Program Director and really the driving force behind the development of the Young Dementia Network in the UK. And like I say, I've been following her for a long, long time and always wishing that we had something like it here in Australia. And I have been, let me tell you, seeding the idea every opportunity I get. So I'm hoping it finds some fertile ground. So Tessa's not able to be here in person, and due to the time difference, she's kindly pre-recorded her presentation. And the aim is to showcase the network and how it operates to influence and drive change to benefit the lives of people living with young onset dementia and their families. So here's the question. Is it a model that we can emulate and adapt to progress action on young onset dementia here in Australia? So let's watch and listen for the next 20 minutes and with that in mind, and we'll reflect on that afterward.
Thank you for inviting me to take part in your Young Onset Dementia Summit. I'm Tessa Gutteridge, Chair of the Young Dementia Network, and I'm Dementia UK's Programme Director for Young Onset Dementia. I'm going to tell you about the UK Young Dementia Network. Ours is a particular model born of circumstances at the time, which has evolved and is evolving. It's pragmatic, collaborative, and it depends on volunteered expertise, and there are pros and cons to the model. I'll share what's been important to us in case it's important to you. Straight to the purpose of the network. To improve the lives of people with young onset dementia and their families now and bring about significant changes that will have lasting benefit for the future. As you know, young onset dementia affects every aspect of life. But to make a difference, we have to focus on just a few that are priorities for the members. So specifically for us, we aim to improve the experience of diagnosis. We aim to increase access to lifelong support and ensure a better understanding and awareness of young onset dementia amongst the public and professionals. So what is the UK network? Well, it's an online influencing community primarily. It's a collaboration, if you like, of like-minded people. It's the first and only national entity for young onset dementia. It has its own identity and brand and its own platform and communication channels, and I think that's really important. It's a focal point to drive systemic change in services and support nationally and locally. And as part of that, we have to raise the profile of young onset dementia and to share knowledge about young onset dementia too. It's also a focal point for individuals to send a message, you're not on your own. This is for younger people with dementia, family members and professionals too, who often feel isolated. There's a community that you can be part of, which understands young onset dementia and what's needed. So to the membership. We have over 5,600 members so far. We're ever growing, and particularly in the last 12 to 18 months. We have an informal membership, no subscriptions, no fees. We have a mix of passive and active members, and some are really core to the activities. Around 11% are people living with young onset dementia, 30% are family members, and over 50% are health and social care professionals and young onset dementia service providers, and the rest are academics, researchers and other activists. So why set up the network? I was director of a small young onset dementia charity, ambitiously called Young Dementia UK, which in its early years established award-winning innovative support in one particular county. Looking beyond, we observed that services and support for the many people with young onset dementia and their families was inequitable, fragmented and patchy. And like you, we wanted to set up something that would make a difference to those people living with young onset dementia who had no voice. Could we develop the catalyst? The issues faced were repeated time and time again, issues which you will recognise. The experience for most younger people with dementia and their families did not enable them to live as fully as possible, from pre-diagnosis to end of life. It took years to get an accurate diagnosis, and damage was done meantime. People were further disabled by the ignorance of those surrounding them. We identified national government and National Health Service, who set policy and guidance, were pretty silent on young onset dementia. Even though young onset was different, the impact was different and needed a different approach. We felt no single organisation could improve the situation and sustain that improvement, but perhaps a determined network of people and organisations could. We felt it was important to nurture and pool expertise, harness the passion and the energy, identify the evidence and the leverage we needed to improve the present and the future. So, back in 2015, we identified experts, including activists with personal experience, and personally invited them to participate. We felt it was very important to have senior academic researchers who had that depth of expertise in young onset dementia, because that's provided us with more robust evidence. We felt it was very important too to have a range of clinical roles for that day-to-day experience. And we had a senior representative from a dementia media and events organisation, and all the invited individuals needed to be well networked themselves. Charitable trust funding enabled us to launch within a year from our starting point. They were interested in young onset as an underserved community where there were challenges but with potential to live better. This funding enabled us to employ a dedicated staff member, and we set up comms and channels and created a brand. We didn't seek government funding. Our preference at the time was for the network to be independent of public funding. So how does it work? Well, the invited experts form the steering group. We asked for a sign-up to a collaboration agreement. Steering group and working groups currently include major dementia organisations, many of whom have been our founder members. So the Alzheimer's Society, Alzheimer's Research UK, Dementia UK, Rare Dementia Support, and involvement networks for people with dementia, and we have contact with Family Member Involvement Network too. So the steering group strategise, prioritise and plan, and the working groups, and we have 3 of them: diagnosis and support, research and evidence, and understanding and awareness, and they're led by steering group members, and they make things happen. So on the left of this slide, there's myself, Catherine and Kate, and we're the 3 part-time paid staff. About the equivalent of 1.5 full-time staff members. But we, to be honest, punch way above our weight. Young Dementia UK merged with Dementia UK back in 2020. Young Dementia Network, established by Young Dementia UK, was considered an asset and transferred as part of that merger. Together we felt we could create a stronger, more powerful voice for people with young onset. The benefits, well, Dementia UK has an excellent reputation as provider of specialist dementia nurses. It's a growing charity, ambitious, well-funded and successful, and importantly for us, understands that young onset dementia is different. Dementia UK has the ear and respect of the National Health Service, especially through Hilda Hayo, Chief Exec and Chief Admiral Nurse, who is a young onset dementia specialist. Young Dementia Network gained credibility and profile through the relationship with Dementia UK. And we're about to begin planning our next 3 to 5 years, and we can do this with much more confidence, hosted by Dementia UK. We drew up a hosting agreement that preserves the autonomy of the Young Dementia Network. It doesn't remove all the challenges, but it does reduce them, and of course we align on values and ambitions. There are mutual benefits too. Dementia UK provide the support to people with dementia and their families, and Young Dementia Network doesn't offer direct support, so we can confidently signpost to Dementia UK. Excuse me. Dementia UK is now developing itself as a young onset dementia centre of expertise and the go-to charity for families. An example of this is the investment in the appointment of a consultant Admiral Nurse for young onset dementia and for children and young people. That's Jules Knight and Hannah Gardner, who are pictured here. Dementia UK is more recently developing its campaigning capacity. Hosting Young Dementia Network is an essential element to this ambition because we offer a ready-made influencing community, young onset dementia expertise and much else. And there are practical benefits too. We're currently working together on developing a young onset dementia pathway from pre-diagnosis through to end of life to introduce to all areas of England initially and then other UK nations. And together we've compiled a professionals contact list and have created a National Health Service map for young onset dementia. This is a unique compilation. So to impact. For the past 3 years, you may have noticed, have been a very unsettled period in terms of politics, health and social care, economics and society itself. But throughout we've adapted, we've taken opportunities where possible, and we've kept going. So what have we achieved? Well, increasing awareness nationally of young onset dementia. The network has definitely contributed to this and continues to do so. The network is a conduit for messaging, such as why we prefer to use young onset instead of early onset, to avoid the confusion with early stage. And we highlight the impact on children and finances and work and such like. So the difference, we highlight the difference. We provide many avenues for those with personal experience to tell it how it is. We had a recent call out for exactly this earlier in the year, and over 200 individuals responded with their personal stories. We wanted to raise awareness of young onset dementia in non-specialist professionals for when their paths cross families affected. This is pretty slow, but there has been some progress. So in terms of improving understanding of young onset dementia, we very much wanted to do that. The key reasons people join the network are to help improve young onset services, improve their understanding of young onset dementia and receive information. We have various tools to improve understanding, and feedback indicates that we've hit the mark. Through the Young Dementia Network site, which you're welcome to have a look at, we give access to research and evidence, webinars for professionals, information about young onset dementia, and resources that we've developed to improve understanding. So homing in on that webinar program, well, this is easy access to young onset expertise. It's through a regular young onset dementia webinar program with over 3,300 registrants for the recent 10 webinars and 2,000 attending, and many more people use the recordings and catch up on the recordings. Feedback and satisfaction for these webinars is absolutely excellent, and I know we've welcomed some Australian attendees to these. And then the resources, thousands have been downloaded and mailed out. In truth, we don't know to what extent they're used, but when we do get feedback, it's good, but it's not thorough. We need to improve on that. We have created resources for individual and family members, ID cards, for example, for primary care, for clinicians and local service development and commissioning. We also send out regular newsletters to keep members informed, keep that community connection. And then in terms of involvement, it's really important, isn't it? Because people want to use their experience to improve the future for others. They want something worthwhile to do, something that they value. So we've opened up many more opportunities for younger people and family members to be involved in research, present at conferences and webinars, contribute to national and local consultations, and shape what the Young Dementia Network plans, shape its resources and its activities and such like. And similar for professionals, we've opened up opportunities of similar types to professionals, but obviously a different perspective is offered there. And then in terms of policy and public affairs, Young Dementia Network has contributed to and featured in national strategy, policy and guideline consultations. We'll put a young onset perspective where there may be none. So we'll ask the question, what about young onset? Here's how it's different. Here's what needs to be done to work for young onset, and we want it to be explicitly including young onset. Recently, we accelerated our campaigning work. We initiated a project to improve the experience of diagnosis for people with young onset dementia and their families. We shared this project with the Dementia UK Policy Campaigns and Public Affairs team, who took on the leadership of the parliamentary work. And they've made some headway with that, with young onset appearing via MPs' questions and such like. And together we're encouraging the implementation of a young onset dementia pathway in every area of England, which would also include a lead young onset clinician in memory services, a commissioner responsible for young onset dementia, and a young onset dementia expert by experience forum, and a key worker, similar I think to the young onset navigator that you've proposed. We need NHS, National Health Service, to require this of the local areas. And then we had to improve research and evidence. Accurate data on young onset dementia has been difficult to find, and that's, I think, similar to your own experience. Without that, it's a real challenge, isn't it, to put a case for improvements. We've been instrumental in estimating more accurately the prevalence figures for the UK and for each nation within the UK and then locally too. And Young Dementia Network with Dementia UK and others has worked to encourage all key organisations to use the updated figure, over 70,000 people. So next we're working on a proposal to improve coding of young onset dementia so that understanding the diagnosis numbers is more accurate and so that the individuals themselves have an accurate diagnosis. We're heading in the right direction on that. And then there are 3 prominent academic researchers, all network steering group members, who successfully undertook the largest ever UK young onset dementia study, the Angela Project. There are lots of publications that are available to you. Provided much needed evidence on both the current situation of people with young onset, but also what works well for people with young onset, which we continue to use to support our case for change. We keep in touch with the Dutch Young Onset Dementia Knowledge Centre too, collaborate on international dementia research programmes with them and on webinars. So, what do members say about us? Well, we still have a long way to go and we have lots to do. We have not got it all right by any means, but we are heading in the right direction. We've been able to accelerate our activity in recent years. Whatever your networks looks like, you'll want the endorsement of people living with young onset dementia and family members. So I wanted to share a couple of ours. The sense of connection between service providers, people with young onset, and researchers provides a powerful vision of putting together knowledge and influence. Could not have said it better myself. And then the network gives me a voice. Instead of a voice in the wilderness, I'm now part of a choir singing in unison. It gives me comradeship and the support of others on the same journey. The network has got my back. Finally, a few parting thoughts from me to you. Keep people with young onset and their families at the heart of what you do. It's easy to let services and organisation agendas take over. Be ambitious, realistic and determined and don't let up. Have a distinct young onset dementia identity and branding even if you're hosted. Including in that identity a distinct site, I think, communication and social media channels. The network needs its own mouthpiece. Let it develop its own voice and keep the focus firmly on young onset at all times and don't dilute it. For this reason, some dedicated staff would be valuable. Most of the people on the steering and working groups, to my mind, need to be genuine champions who have expertise, passion, time and determination. They need to be senior, and it's not enough just to represent an organisation because it's your role. You need to mean it and you need to feel it. Put aside organisational and professional egos. Commit to working collaboratively. Achieve more together by that means. And agree a collaboration code which shares kudos. Commit for the long haul and throughout find ways to keep yourselves motivated, energised and positive. Establishing and sustaining a young onset service nationally is a challenge, so include those short and medium term achievements so that you can keep control over them, but also so that it keeps your spirits up. Make sure that people enjoy being part of it. Keep the blend of personal and professional expertise. Keep positive, identify solutions to the issues and offer multiple ways to be involved. And then keep growing. Especially look for ways to grow expertise across a range of professionals. Keep enabling new voices and strengthening existing voices, and keep looking ahead for opportunities to embed improvements. We wish you every success with shaping the future for young onset dementia. It must be done.
So Tessa says it must be done, and I say it can be done. And in WA, only as short as 2 months ago, with the help of my colleague Alan Blackwood, we facilitated a forum called Shaping the Future of Young Onset Dementia in WA, and it attracted 80 people, really representative of all the stakeholders across disability, aged care, community care and health. Out of that, we now have 23 members on a steering group committee, including 5 with living experience of dementia. And already we've prioritised 6 action areas, and we will develop working streams against those. We have a webinar series that we are developing, kick-starting at the end of this month. And in fact, this week we've got a group gathering to look at our theory of change so that we can really get clear on what our purpose is and what our impact statement is. So we might be the catalyst for something bigger across the whole of Australia, let's hope. So I guess I don't want to go into too much detail about that, but, you know, watch us and, you know, we'll lead the way in that space. But just right now, I guess, has anyone, it'd be interesting to get the reflections and thoughts of people in the room and, you know, do you think the value that this might be going forward, and a place where we can really actively capture, look at what's working, not working in and around Australia, do more of what's working and how that might change outcomes for people living with dementia and their families. So I'll open it to the floor.
I'm a social worker and I work for the Old Adult Mental Health and Wellbeing Program at Eastern Health, and over the years I've seen a number of people with young onset dementia, or someone that had the symptoms but was not actually diagnosed until they were over the age of 65. Is there any kind of thought about including social workers in all of this? Because, you know, there's nurse educators and that, but I'm just thinking, it hasn't been mentioned, and the role of clinical services in managing some of the issues, not just the behavioural issues that may arise, but also supporting the family, doing some really good family work, psychoeducation support, organising respite care, because I find that carers are overwhelmed. They are grieving when they get given a diagnosis that your loved one has an early onset behavioural variant, you know, whatever, BPVD, whatever type of dementia. There is a lot of grief, and they actually need someone to journey with them, not just to give them a page of resources that they can actually read.
Okay, that's great. And really, as I said, the network that we're developing actually encompasses all the key stakeholders. So it has OTs, it has physios, it has social workers, it has researchers. We cover the full range. And already, and I'll give you an example, we have in WA 3 McCusker nurses who are funded by the McCusker Foundation and look after supposedly all the people living with dementia in WA. What we did discover, and because we've aligned ourselves with the Neurological Council of WA, because they have a whole raft of neurological conditions under their belt, and we're on their leadership forum as well. So they're hosting us at the moment, which is good to piggyback on their resources. And we discovered they have one of the biggest nursing teams in WA, and we're going, why aren't they servicing our cohort? So already we have discovered through this process of looking at what's happening in the exemplars in our local area, we're able to leverage the existing resources. And to answer your question directly, my husband is one of those that missed out on NDIS by 3 months, so I'm acutely aware of the shortfalls of the system, and it's pretty much why I do what I do, pharmacological route, and he's still living very well with dementia 12 years further on. So any other reflections?
Hello, I'm Rebecca, occupational therapist working in the community. I guess listening to Tessa and the network that they've developed over there is quite inspirational. Having worked in the community health and now also in privately for a number of years, it's been really annoying, to say the least, to not know who all the people are, even in this room, with all the expertise and all of the abilities to assist clients that you see on a regular basis and not be able to put them into contact. I recognise I can only do so much, but there's so much more we could do if we actually worked together and had a coordinated response. I think it would help hugely for people, obviously, with dementia and their carers, and also in allowing the clinicians and the support teams to be able to carry on the work and not feel burnt out as well, being able to try and provide the support levels that people with dementia do need. So I think it's amazing. I think also being able to find a one-stop shop where we can go and find those connections and being both the person with dementia and also and the carers and also the clinicians to be able to access that at the same time. We shouldn't be, clinicians and those people working with people with dementia shouldn't be the ones who hold all the knowledge. I sometimes feel like I hold all this knowledge and I need to give it to you. I shouldn't be holding it. You need it. The family and the carers need it, not me. And we need a way, and this seems like a really great way to be able to do that. So I'd be very keen to get something like that happening. Yeah,
that's great. And I guess just speaking to that, I've done a lot of work in the social impact space and that collective impact. We actually we're going, rather than being a community of an online influencing group, we're actually going to be a collective impact network. So the beauty of being able to get together and look at what's happening and what we're all doing and breaking, finding the linkages, leveraging what already exists. We don't have to reinvent the wheel. It's not about more funding. It's about how we make better use of what we already have and where are the assets in our working space. Over here.
We talk about the holistic approach. The one thing I think there is a gap is around young carers. And I just wonder what will be happening in that space, because what you're doing is fabulous, what we're trying to achieve. But I have a daughter that's 20 that's actually my predominant carer for my husband because I have to go out and work. And I don't believe there's actually too much out there. Or is it the fact that the communications around the young carers, are they appropriate? Because I know that Craig was saying earlier about his daughter not wanting to seek counselling for whatever reason. I just wonder if we have to look at the approach of what that actually looks like and speak their language to actually get them involved in this process and actually, again, provide you really significant feedback to actually give you that holistic approach as well.
And look, that's the whole point of the network, is we can draw on those people and identify them in the network, and then they inform what we, by listening and hearing their voices, they inform what action and what solution we need to take to address the shortfalls in the system. So that's actually part of the whole process, and the reason for being is so we can do that. And in the Young Dementia Network, the peer group that I founded 8 years ago, we actually have 140 carer couples. We've got, our youngest member is a 42-year-old with a 3-year-old son. We have them as young as 5, 6, up to 15. My girls, I was only married for 3 years. My girls' stepchildren were 12 and 17. So it's difficult. I know the challenges, but that's, again, why we need to do what we're doing.
Hi, my name's Nat. I'm a young carer, so I thought I should...
Great follow-on.
I'm also a psychologist at Eastern Health's Older Adult Mental Health and Wellbeing Service with Maria and Karen, so have both perspectives, I suppose. I was 19 when my dad was diagnosed, so I know exactly what your kids are going through. Sorry, it's still hard to talk. Yeah, but there's no support for kids, so I just wanted to validate that point. I think it's when I was, so I'm the oldest of three. My youngest sister was only 15 when Dad was diagnosed, and it was 2 years before that we started the process. And I think at the time we were all just a bit overwhelmed and didn't know how to process it or weren't ready, but then there was no kind of follow-up after that. So I guess what I would maybe recommend to everyone in the room is to not forget about kids and young carers and continuously follow up with them, years down the track, not just offering that support at the time of diagnosis. So.
And I have to say, some of the work we're looking at, there are some spots around Australia where there is some good work being done in that space. Brightwater, I know I've worked alongside, has some really good resources for young people and young carers. Also, Dementia Australia, I have to say, have in WA a family engagement counsellor, and that's been very useful to our members as well. So it's out there, but you just need to know, I guess, again, where to look, and there are gaps for sure in different areas. So
yes,
anyway.
Vicky, I just wanted to echo that about the supports for children. There are some social peer group support networks through Dementia Australia, in fairness to them. It's just that my children in particular were resistive to going into that, and that part of it's the stigma attached to young dementia and being singled out as being different to other people, and that's where the resistiveness came through. So we need to look at creative ways of reaching those children, that market.
Absolutely. Okay, I think time's pressing on, Bronwyn.
I'm hearing that. Please, everybody, thank Vicky for doing wonderful work. Right, well, we're getting towards the end of the day, and this final session...
Sorry, I just wanted to mention that website, Dementia in My Family. Does Dementia Australia still have that up and running? But that is a fabulous resource for kids. So it's got big buttons on the front that have age groupings, and it's just they can access counselling, I think, through that too.
Right, thank you. You project? Good. Go for it.
At the risk of my team shooting me when I get back to the office, because I'm doing this without anyone. I can't hear all the noise.
I just want to say, to repeat what I just said, at the risk of my team shooting me when I get back to the office because I'm let loose and out unsupervised. I do think that there is merit to that presentation, and I also just want to congratulate Vicky on her incredible advocacy as well, so I think it's important to recognise that. And I think that some of those key things around let's not duplicate effort, let's utilise resources that are there. And so I think that opens up a really exciting conversation that we need to continue. That's all I wanted to say. Thank you.
Thank you, Tanya. Well, I guess so far we've heard that there's quite a bit of work to do. And our final session is going to look at just what shape that work might take. I think at the moment we're going through some significant changes in the NDIS area and the aged care area. Modern government, and particularly the reform in disability services, is being done with co-design with people with lived experience. And this is an approach that goes well beyond simple consultation.
So the Young Onset Dementia Special Interest Group recommendation for people with lived experience to have a central and a structured voice in reform is highly relevant to this. The project believes that a system of care for people living with young onset dementia must include an organised voice of people with living and lived experience that interacts with all other parts of the system. This doesn't mean, though, that people with lived experience have to carry the can and do it all themselves, quite the opposite, but they should drive it and have a say in setting the agenda for government and funded organisations. As I said at the start of today's proceedings, we're at the beginning of a reform initiative that needs all the vast and varied expertise of researchers, clinicians, peak bodies, service providers, policymakers and people with living and lived experience of young onset dementia. And to get this job done, we've heard the word collaboration being mentioned a bit. It's definitely collaboration we have to do, absolutely. We've talked with a lot of people through the project's work and they've confirmed the YODSIG findings and reinforced that we're a very long way from where we need to be. I'm going to invite a group up onto the stage now, so can I get Craig, Luke, Robin and Jim and Vicky, I'm just counting heads here, to come up onto the stage. The group of people that are making their way up now have been working through these issues and have crafted the call to action that's on your table to take the YODSIG recommendations one step further. This is one step of many, but some very good thinking has gone into this over a significant period of time. The YODSIG recommended the development of a consumer and caregiver-led organisation to prioritise the needs and the concerns of those affected by this condition, to increase public awareness and to address the stigma that people living with young onset dementia often experience, and we've heard about that quite considerably today. Craig, I'm going to come to you first. You're over on the end there. You were hoping to hide, but you can't. You've been part of this group that feels an organisation like this is very important. Can you give us some idea of why the group thinks that and how the other items listed on the call to action are going to help us get further down the track to where we need to be?
Yep, thanks for that, Bron. Dementia Australia estimate that there are currently 421,000 people diagnosed with dementia. So the younger dementia cohort is only 30%, roughly 7 or 8% of that total. So currently the services are geared to the geriatric sector or the over 65 sector at the moment. So we need to try to shift that focus if we can. One of the big things that everyone's been banging on about, and I think they agree with, is the navigation system there. So the thing from a personal perspective that would have helped me from the beginning, I was actually our speech pathologist over there, Margaret Posabon. She's cringing at me mentioning her name, but we all have a common link here, and that is Margaret Posabon. So we're actually interconnected in that way through her. But what's been missing is actually that peer support, and so actually knowing where to go. So when my wife received the diagnosis, I sat down and I wrote Venn diagrams for every member of the family, including myself, 4 foolscap pages worth, and then I started working on the to-do list. But it was just so intense, and it's 3 years on, I'm still like the little duck paddling away, working my way through it. So it's about establishing that navigation system, actually being able to talk to someone. I know there's some resistiveness apparently with some people about talking to other peer members, but I would have found that support vital to actually go through some of those key financial steps. You know, where do we go to here, you know, with the NDIS?
So having someone who can help you navigate the
core supports to go through
systems.
that. And that's probably, I think it needs to be not just peer support, it needs to work hand in hand, collaborating, as you say, essentially with academics and clinicians. If it's run simply by academics and clinicians, you're going to miss out on some of the vital information.
Yes.
I don't think that's what anyone here wants to do.
But that's the importance of a carer and consumer-led organisation, yeah?
Yes.
You get the lived experience coming through.
Yes.
Right. Thanks, Craig. Luke, can I ask you, you've had a bit of experience in this field, and I believe it's your wife Lisa's birthday today.
It is, yeah. Yeah.
And you'd probably be with her, but you've made the effort to come here, so thank you for that, and happy birthday to Lisa.
Yeah, she'd be happy with me being here.
Would she really?
Yeah.
Right.
Yeah.
Luke, I wanted to ask you how you see where we're up to at the moment and where we need to be in having an ecosystem of services and care for people with young onset dementia and their families.
Yeah, I think it's well overdue. I think it's an exciting time. I've been able to make it to a few different conferences this year, and I've seen that really build in momentum and engagement, and see a lot of great people trying to do great work. So I think it's well overdue. That's a personal story. I can hear it with Craig. It feels like we're always catching up to what's needed and where we need to be. And Craig's, three odd years in, and I could say I'm probably 5 years in. And where I'm at in that journey is I'd still say I'm 3 months behind, trying to get services in place for Lisa that she needs now, or that she needed 3 months ago, and they're only just starting to come in place. So an organisation that can help to speed up that service provision and delivery will make enormous support to carers and individuals and their families.
You've used the analogy of a Rubik's Cube, I think, haven't you? Saying that when you're dealing with young onset dementia, it feels as if you've got one side of the tiles organised, you turn it around and then it all shifts again.
Yeah.
And you play constant catch-up. Is that right?
Yeah, that's definitely how it's felt. It's easy to get some pieces into place, but it comes at a cost, and you're always missing things, and you don't know the way to solve it. There's a trillion different ways to solve a Rubik's Cube. It feels like that is the journey ahead when you get a diagnosis in the situation, the complications of your own family's circumstances, etc. So it very much feels like trying to solve a Rubik's Cube, and it would be great to have one of those little masters that can spin it super quick, that's it, and sort it all out, give it back to you.
And that's giving people with young onset dementia and their families a voice. Yeah, right. Thanks, Luke. Robin, you've been on this journey with your husband, Wayne. How does your experience inform your thinking about having a voice yourself, and what would have made a difference for you and Wayne when you were diagnosed?
Yeah, well, we're 6 years in now. Wayne was diagnosed in December 2018 at the age of 51. Unlike others in the room, our diagnosis was timely. We've got a GP that knows us for almost 30 years. He's known us and recognised the signs and symptoms pretty quickly, and got us in to see a neurologist pretty quickly. So by December we had the diagnosis, but I will never forget leaving that room. We were told to get our affairs in order, start to tick off your bucket list, and Wayne will have about 8 to 10 years left of his life. So like someone else said, that first 12 months was a blur of grief. But then I've always been one to have my ducks in a row and try and get everything sorted. I wanted to be the best carer possible for Wayne, and still do. But then I quickly discovered that there wasn't much out there for the support for what we needed, and what these uncharted waters of what comes next. Can he work? Can he still drive? What do I do? How do I tell the children what support is in place for them? So I think back then, if I had this organisation, this helping hand that was there, that I could grab and have all of that knowledge and support of what I could do next, would have been invaluable. 6 years down the track, I have so I'm so happy that I have the right support I feel in place going forward. But like Luke said, you just don't know what the next and when the next stage is going to happen, and when the decline stage is going to be. So to have that helping hand and to have that organisation there would have been invaluable.
Really important.
Yeah.
Yep.
Yeah.
Thanks, Robin. Jim, I said before that every person's journey with young onset dementia is different, no two are the same. If this is the case, how important is it for people with lived experience to collaborate and co-design the services that are so needed, do you think?
Okay. I prepared an answer earlier.
This wasn't staged.
Thanks, Bron. Great question. I want to slightly digress from that question, though, because I want to discuss about really what brought me here. And I think this is the same thing that's come up over and over again, but I do feel that it's so important. So my journey began about 3 years when my wife received a diagnosis of frontotemporal dementia, and she was 61, and I'm 74. So it's a diagnosis that's changed the life of everybody that knows and loves Louise. She was expected to continue her career as a Feldenkrais practitioner well into her 70s and look after me. But that just doesn't happen, you know. So Louise continued to provide sessions for clients well after the diagnosis. So we kept her going in her work, but there came a time that she could just no longer continue her practice. For me, the diagnosis meant a rejig to our lives. And I need to begin to learn and understand what the future would be, and very fast. Anyway, early on we had a very good speech pathologist, and she suggested Louise should apply to the NDIS and that she would give us a hand. She went on to do a PhD and just didn't have the time, couldn't...
How dare she?
How dare she? Look, I actually think it's fantastic she's gone on to do a PhD. Anyway, but she did recommend another speech pathologist, Dr. Margaret Osborne.
It's not an ad for you, Mark.
Yeah, well... Margaret immediately advised us to apply to the NDIS. And this is the little part that I want to say. So the initial application was relatively straightforward, but this application was rejected. We then appealed the decision, and we provided further in-depth reports from our specialised psychiatrist and occupational therapist. The initial decision to reject the application was upheld. But here we are, 2 years after a diagnosis, still trying to digest the implications of this situation, with what appeared little likelihood to access to the NDIS and high levels of anxiety for myself and Louise. Should we appeal to the Administrative Appeals Tribunal with lawyers and other experts, or should we give up and walk away? Where to go from here? What would you do? I mean, 2 attempts, no luck. I need to say, Louise, we're really lucky that we have 3 angels on our side. I won't say who they are. They know who they are. Anyway, with these angels, we're able to obtain access to the NDIS, and I thank the NDIS too. This enabled us to determine a path for our future, and at least one of the unknowns becoming a known, and that was the financial direction and assistance. But what of others? How do other people navigate this issue and 1,000 other practical matters that arise when caring for our loved ones with young onset dementia? But what if in another universe, at the beginning of Louise and my journey, there was an advocate or champion? It's been said before, but it's so important. Who could have guided us when we really needed it? This doesn't have to be one person, but needs to be a connected group of individuals who have the experience and understanding of what it is like for an individual, couple or family, one of which has just been advised of a diagnosis, and what strategies will provide a pathway for the best life that is possible, with the minimum of doubt and anxiety for everybody involved. Now, getting back to your question, Bronwyn.
Thank you, Jim.
I'd like to say that the professionals I've worked with have been truly wonderful. However, when I meet people further down the path than myself, I'm impressed by the amount of day-to-day practical knowledge that they have and that I find so useful. I've got myself involved in finances, and perhaps I'm lucky as I'm now retired and I have time. For many of my other carer friends, they need to work, they need to pay bills and juggle the other complexities of life as well as caring for loved ones. My involvement includes joining carers groups, or sometimes I find myself having a chat on the nature strip outside the drop-off point for Louise when she goes on a supervised day outings. However, one thing I've found is that people who are caring have quite different needs. Why should we be surprised? Each of our loved ones has unique personalities, and the situation for each loved one and carer, whether it be financial, housing needs, accessibility to services nearby, and the availability of family and friends to help, will be all different. And also the capability and sometimes the behaviour of loved ones can be very different. For some of us, the emotional changes of our loved ones can be significant, even from hour to hour and day to day. I said to Bronwyn at one stage, I wish Jim now, that's me now here, could speak to Jim 3 months ago, and he'd say, things will be all right, and here is the information you need. Anyway, there we go. Professionals are great, but we also need our voices to sing together so change can be made. But sometimes you'll also need to sing solo so individual needs can be heard. It also means our loved ones need to be individually tailored by learning and working with others in a similar situation. To answer your question...
Third time lucky.
Yeah. From my point of view, it is really important for people with living experience to collaborate and co-design the services that are needed. All great movements start with those that have a need. This is why we are all here today. Thank you.
Thank you, Jim. Before I respond, I'm going to turn to Vicky. Vicky, you've been a peer support leader for some years, so how have you seen the lived experience voice make a difference? Can it make a difference?
It certainly can, and I think the one thing, and it was interesting in one of those slides up there, it said that sometimes people find in the research connecting with peers confronting. That hasn't been my experience at all. In fact, it's been a relief for people because finally they say, we're not alone. They've actually found, because really at the end of the day, we're living this thing 24/7 with no let up. And I feel if, we're not the professionals who come in or care support workers for 1 or 2 hours or whatever, we're actually left holding that space 24/7. So I think we are very well positioned to give each other support and help redirect, find services that we need and, learn from each other's experience. And absolutely no two journeys are alike, that is for sure. And some of it will be useful and some of it won't be. Can our voices, can you just give me the original question again?
How can the lived experience make a difference?
Okay, well...
Dorothy Dixer, really. Of course we know it can.
What I'm going to share with you now, this came to me because I've sat over the years on many different projects and advisory groups, and two of the best that I can honestly say were a really good experience. One was Alice, Principles of Community Engagement with Dementia Australia. If you want to know how to use the people with living experience and lived experience really well, that was a fabulous piece of work. Actually, there's 3. The other one was supported decision making. Michael and I in the early days were on the National Advisory Group that got the guidelines up for supported decision making, and I can honestly say he was so proud of that work. And it was good to have his voice there. And then more lately, I've been sitting on 3 years on the Dementia Training and Education Standards Framework alongside Jason and, Jason Burton, how could I forget his name? And at the very end of that project, one of the people in our peer group said, what's the one thing, and Jason's a guy who's had over 30 years experience in the dementia space, was a mental health nurse, and one of them said to him, "What's the one thing in all those years of experience, Jason, that you think's really made a difference in, the dementia space?" And I've listened to people around my table say, "We've all been doing this for the wheels are spinning, they go round and round, the dial's not moving." Jason's response was, "At last we are listening to the voices of the people living with dementia, and it's been a game changer." So really, that's all I need to say.
I think so. Thanks, Vicky. I'm just going to throw it over to the group now to say, has anybody else got a comment they want to make about having a voice? Because what we're hearing is that people think that their voices aren't heard and need to be heard, should be heard. And so we're thinking about an organisation that could do that could provide the support, the walking with you, the information, and help direct to the services. So does anyone have anything else they want to say?
I feel like we need a voice to the general community as well in terms of raising public awareness. And it's not just young dementia, it's dementia in general and the stigma that is attached to that diagnosis. And, I personally see that from my wife's family in particular. They've all buried their heads in the sand and basically we don't see them. When we do see them, I receive basically free advice. So that's not really very helpful. But I think part of it, I understand the place where it comes from. They're actually frightened themselves, and even though it's unlikely that it's a hereditary thing in their family, genetic, I understand their reluctance and reticence, and we live in a more remote location as well, which makes it quite difficult. But I really think that in general, society, you've got people with younger onset dementia, I keep saying young dementia, who are working in the community, and it was touched on earlier, about those people need to be supported to work in that environment. And by the time these people get to the point of being diagnosed, they've probably been discriminated against in many cases, and they've probably already lost their jobs beforehand. It affects the welfare, the well-being, the financial wherewithal and mental health of families.
Thanks, Craig. Luke, have you got anything you want to add?
Look, it's just been really great to be here, and I think Craig and the team here have said exactly what needs to be said.
Good on you. Robin, Jim, no? Doesn't have to be.
It's been an emotional day for me, actually, as the day's gone on, listening to all the stories and just knowing that you're not alone. And I have so much hope for this. It's been amazing,
Jim, anything you want to add?
I think I've said
You've said enough. Good on. Right. Well, on the tables in front of you... We're moving on. On the tables in front of you is a call to action that this group have put together and worked over quite heavily. It calls for the establishment of a carer and consumer-led voice, and it lists 5 particular areas that voice would be focusing on. And I don't think there would be much disagreement with any of those. But I wanted to ask, would people here in the room support the call? Do you support having a voice, consumers and carers? Can I see a show of hands? Yep. Thank you. That sounds great. It's not meant to be a separate thing. This is a step in the right direction, I think, but it does articulate that people want to be heard, have a lot to offer. And I think the other part of it is the co-design, being able to work with government or whoever is doing this work to make sure that what is being done is actually going to work for people on the ground. I'm just thinking about the Rubik's Cube, but the thing is spinning for me at the moment. But would you please thank our panel? I've got a note here that says next steps. next steps, I think, are going to be a couple of things. We've got the reports that the consortium partners have developed available. They'll be up on our website. Our website's been down, unfortunately, had a crash, and we would have had them up there, but they will be up there for you to look at. We'll also endeavour to put the presentations today up on the website as well, and we'll communicate this to everybody. I said at the start, if you had a question that wasn't able to be asked today, to please let us know. And I hope people online have been using the Q&A function to do that. Sam?
I was just going to say, with the report, we are developing it.
Penny doing a great job there.
I was going to say, with the YOD-SIG report, we are creating an easy read version as well, because we understand that we need to be accessible for everybody, so we are in the process of creating that version as well. So that will also be in the website once we finalise and have people with experience have a look at it and make sure it is easy read. So watch this space. Thank you.
Thanks, Sam. I think the other next step goes to Vicky's formation of the network in WA. I think we need a network in every other state, and I was going to ask Vicky if people could join from other states, but I think we need our own networks. It's all about the local situation. Vicky, am I right?
That's right.
So,
Tessa made the point, the local and national. I believe there does need to be a national network, but I think it needs to operate on the ground in each state, because we should be leveraging the resources and the way things are organised collectively in that state and in the regions as well. So, yeah.
So if we offered to set up some networks, are people interested in participating in that? Can I see a show of hands again? Yep. Okay. So we'll endeavour to reach out to you following the summit and start to do that. We've already got a network of providers that we've brought together who are interested in dealing with the way the NDIS looks at people's plans. And another thing I did want to say in conclusion was that the NDIS has been pretty poor over time in understanding young onset dementia, but, and I think I can say it's because the project exists and because it's in the space, they are now taking notice and they are trying to do better. We've still got quite a way to go, but they've set up a it's got this extraordinary name, neurodegenerative working group that Dementia Australia and we are on, and we're hopeful that that will start to make some strides in how the scheme works with people with dementia and the planners. So there is a small team there at the moment who is very committed to continuing to work specifically with this group, and we've been pushing for a similar pathway to the one the Motor Neurone Disease Association managed to get, and I think we're going to get there on that. Don't know when, and it does need everybody's support to get there. So I can't remember who it was who talked about local government, but if you don't find anything happening in your area, everybody has a federal and a state politician and should go and tell them what you want and make it known that way. But we'll set up some of the networks and see if we can get things going in that way. I think that's about it. One thing I also wanted to mention in terms of thanks was to Victoria Hollick from the team who has done all the terrific presentation, the artwork on them. It's been really fantastic and looks so lovely. So would you thank Victoria? Well, I think that concludes proceedings. We've got lunch outside. Oh no, Julie, I can see you looking at me. Julie and Natalie, when we were talking before, I was so conscious of time. Julie, Natalie and I forgot that they had something else they wanted to say. So do you want to come up here or do you want to speak where you are? Have you got your notes, Julie? I've got them. So my apologies, everybody, but if you'd indulge us, thank you. You coming up, Natalie? Great. This is important. Right? You need to be fit to get up here, don't you?
Thank you. Absolutely.
So firstly, I'll just like to say that it's lovely to see so many of you here, and it's really an honour to be invited. So thank you, Bronwyn. My name is Natalie. I'm a devoted mother of 2 beautiful adult daughters, and this also includes one loving, mischievous cat, who also means the world to me. I'm an educator with extensive experience in both mainstream and special education. In addition to my teaching roles, as mentioned before, I work as a freelance research advisor with universities, collaborating with teams on various research projects. I sit on the Dementia Australia Advisory Committee and I'm one of the board directors for Australian Aphasia Association. I also was recently appointed to represent Australia on the Alzheimer's Disease International Global Dementia Expert Panel. In addition, I'm also an international speaker advocating for dementia awareness. I was first diagnosed with mild cognitive impairment in 2018 and later diagnosed with primary progressive aphasia in 2021. I first knew something was different with me when I would have trouble finding words to say or think of them. Now, this was different for me. As an educator, I'm used to talking academically and writing abstracts easily. I would start to use Google or ask my daughters to help me when I had word blanks. At work, I could not recall some of my students' names in the classroom and schoolyard to bring them to my attention. So I would do workarounds to find their names. As if that wasn't enough, I forgot how to fill out student progress reports, which I did daily with relative ease. I did, unfortunately, lose my job and the students I adored. My GP has been supportive of me throughout my journey so far. However, when I first attended the hospital, I felt alone in my journey when I lost my ability to speak and did not know my surroundings or the name of my family members. I felt I wasn't being heard or trusted by the medical sector, which was looking after me and supposed to help. Even if they didn't believe me at the time, some doctors needed a course in sympathy and effective communication. I was left with nowhere further to go. I had to search for myself for a solution. I was thinking on the way to this event how it felt in those dark, unsure times, sitting in my lounge room alone, crying and thinking, what am I going to do? How do I deal with all these symptoms happening to me? But underneath, I had this burning tenacity that I was going to find a way, no matter what it took. As luck would have it, a good friend of mine, Kevin Morris, also an advocate, suggested I contact Kerry-Ann Tipping at the Advocates Program at Dementia Australia, which is why I'm here today. I also reached out to my friends at Dementia Alliance International online Zoom support group, who encouraged me to see my trusted GP for a referral to see a speech pathologist. I followed through with their recommendations. After lengthy tests and appointments, I was finally diagnosed with primary progressive aphasia, a language-led dementia which affects all aspects of communication: talking, understanding, speech, reading, writing, and using numbers. As the disease progresses, mobility and swallowing issues can also arise. It's important to note that the symptoms of PPA vary from person to person, and the person's intelligence is unaffected. Unfortunately, the stigma surrounding dementia has made it challenging to secure contracts within the education system for me. The great news is that I have found work in the university sector, collaborating with teams on various research projects. This has given me a sense of purpose. I cannot tell you how much. I have been recognised for my academic achievements and valued for my contributions. So it's not up there. I will leave you with this one last thought. Many have told me, you don't look like you have dementia, Natalie. I had such an experience at a dementia research conference. I was asked my affiliation and I explained I'm a person living with dementia and will be presenting and speaking on a panel shortly. He said, "You don't look like you have dementia." I asked, "What does dementia look like?" He responded, "Not you." This came from a professor. It is deplorable that people living with dementia face discrimination in all aspects of their lives, and this stigma continues, whether intentionally or through ignorance by some within the dementia medical sector. Unfortunately, this common phrase unintentionally perpetuates stigma and stereotypes. The words we use affect how people with dementia are perceived and treated and impact the support and empowerment they feel within society. Thank you.
Can I ask the tech people if that slide could be put up? Yeah, thank you. Natalie's got a slide with a QR code on it. I think she wants people to see. Is that right?
That's exactly
right.
Do I use this one?
Yeah.
Oh.
Julie, if you want to go ahead.
Sure.
Julie's going to talk a little bit about her experience as a carer.
First of all, thank you. I think it's a privilege to have been able to come here and listen and now speak. I care for my husband, Frank, who was diagnosed at age 58 with young onset dementia. He's now 68, so it's already been a bit of a journey. We have 2 adult children and 6 grandchildren, and that's joy of my life. It took several visits for us to the GP for our concerns to be taken seriously. Then when finally the journey began, all the tests, scans, appointments came back with a diagnosis of frontotemporal dementia with greatly reduced cognitive function. No course of action was advised when we got this. Thankfully, our daughter stepped in and helped us find Dementia Australia, which led us to finding Caledonian Dementia Care, which has been our saving grace in so many ways. Frank has a place where he can shine, really, or he feels so comfortable, and the respect and the care that he receives there is incredible. What would have been helpful would be if we could have been referred to someone who was up to date with services and supports and education to navigate this journey. There's that word, navigate. Thank you, everybody that's mentioned it. Our lives would never be what we hoped for. And there is almost no consideration to whether the carer has the physical or mental capacity to do this job. My job now was as a carer, and that took priority even over my own declining health, and this job is certainly all-consuming. One of the biggest challenges is finding suitable respite for Frank. There is nowhere, and many of us have searched, that can properly care for young onset dementia people like Frank, who are still relatively high functioning, considered high functioning, and need a completely different type of care. The respite available would be detrimental to people like my husband. He needs to be kept active, both physically and mentally. As a carer, I no longer have my supportive husband. I no longer have my shared decision maker. I no longer have my confidant. No more meaningful conversations. Mostly not much conversation at all. And it is very lonely. All these years of 24 hours a day caring put me in a place where I wasn't able to really care for myself properly, and it finally got to me. And forgive me for sharing this, but I especially with everybody talking about stigma of our loved one's diagnosis, if we don't speak up as carers as to the true impact it's had on us, how can anything ever change?
In April this year, I was driving to a carer support group, and I'd been struggling, really struggling. I had to fight the urge of driving my car into a tree. It was the most frightening moments of my life. When I pulled over for a while and then continued. When I reached the meeting, I put my hand up and asked for help. Sarah, who's here today, and Maren from Caledonia jumped into action and with my family got me through. My daughter, who has 3 children, all with special needs, took my husband for a week. And as you could probably all understand, that's not an ongoing respite that I can impose on her. I am beyond grateful to these people. Imagine if there was a suitable respite facility my husband could have gone into when I was exhausted, both physically and mentally. If there was, maybe I would have not gotten to that point. My fear is, what if there is no change? What if that respite is never available? How many more years can I keep doing this? I too am advancing in years. I too have declining health. And there are just so many differences in care, as many differences in carers as there are differences in people with dementia. We just need somebody to look at what the different sorts of carers can and can't handle. And the level of care and the amount of time we can keep our loved ones at home with us, which is where we want them. And that's what, from the word go, that's the first thing I said was, he's not going anywhere, he's staying home with me. But if carers are not helped, this just can't happen. And if I can just say one more little thing is that, and somebody's touched on people, well-meaning people, well-intentioned comments. The one that, 2 things that get to me. One is the first that they say, oh, he doesn't look like there's anything wrong with him. And okay. The other one is, oh, do take care of yourself. Thank you for listening.
Please, thank you. Yep, I'm just going to... We're doing a dance here so we don't fall off. There you go. You right? Okay. Thank you, Julie, and thank you, Natalie. I think they are terrific. They've brought some really important thoughts to mind that I think we can take away with us today. I want to thank the magnificent speakers we've got up here now for their contribution, for their lived experience. This is not easy to do, but as Julie has just said, unless we do it, nothing is going to change. So please, would you join me in thanking these people for their efforts today? We've got one last thing which I nearly forgot, but we've got a feedback form, and I think the lovely chaps down the back are going to throw that up at the moment. We're keen to get your feedback about today. We hope to hold other events like this, and we want to get better as we go along. So if you wouldn't mind, there's a large QR code. If you wouldn't mind filling that in, we'd be most grateful. I'm going to ask you to thank all our speakers again, Professor Amy Brodman, Associate Professor Sam Loy, Dr Claire Beard in England, and the team on the front here. And thanks also to you for being here today and for your contributions. As my brother-in-law said to my father when he married my sister, thank you for all you've done, Harry, and for what you will do. And I want to leave you with that, because we will be coming to you for what you are going to do. We need to work together, we need to collaborate. That's the way we're going to get things done. The NDIS is on the move with this. There's some very promising action happening there. So I think there's great hope for the future. Thank you all very much for being here today. There is lunch outside and an opportunity to further network if you'd like. So please, thank you very much, everybody. Well done.